Good morning, everyone. We will start with part 2 of session 3, mHSPC again. You see all the speakers from yesterday on the stage and also the additional speakers from this morning. And we would like to also mention our social media friends this morning, especially with a special thanks.
Yes, and since that is really one of the ideas of spreading knowledge, so it's very important that we are on social media, and we want to really thank Declan Murphy, who's here with his super camera, and also Reno Ipen, who are the GU cast. And if they ask you to do a podcast or an interview, even if you're tired, please do it.
And in the front here is Jill Morgan from OncoAlert, who is busy hacking away, tweeting with millions of impressions. I don't know what it means, but I'm very impressed by 11 million impressions that we had from day one of APCCC. So this is nice to know, but I think it also helps us spread the message, get people aware of the conference, also of the talks, of the videos that will be online after the meeting for those who have not been able to come to Lugano.
And from today, there is also Brian Reaney and Tom Powers, the Urmigos. So same here, please, if they ask you for interviews, say yes. So thank you very much for helping us to really spread the word. And now I hand over to the biggest panel ever in APCCC, and to Mary-Ellen Taplin and to Karim Fizazi. Thank you very much.
Thank you, Silke and Aurelius. I'm delighted to co-chair the session with Mary-Ellen. So we will continue discussing difficult situations and probably unanswered questions for metastatic castration-sensitive disease. And obviously, one key question is whether we should carry on with systemic treatment. We will ask Bertrand Tombal to start with this first question and try to address whether we can indeed stop treatment in some of these patients. Bertrand, please.
Thank you very much again. My conflict of interest have not changed. So as a preamble to that session, we have now established, and it was clear from today, that the current standard of care is for treating metastatic HNPC is at least the minimum being a doublet in the vast majority of patients with docetaxel or prostate bed radiotherapy, and this being continued until progression. We must recognize, however, that we have achieved great result in terms of making these patients live longer, but it comes with a price. This comes mostly from a real-world evidence series, clearly demonstrating an increase in the risk of cardiovascular events, falls and fracture, cognitive toxic effect, and all of these will be addressed later on. And it has a huge financial toxicity, which in Europe and US may not be an issue, but all over the world is a grow as the #1 limitation to prescribe these drugs. In Europe and abroad, there is now a big movement towards seeking treatment optimization, and this from the start. The EMA, European Medical Agencies, has established the Cancer Medicine Forum with the academic group, including EORTC. We had a very nice meeting on treatment optimization 2 weeks ago. It's on the website. In Canada, there is the Optimal Cancer Care Alliance from Ian Tannock. And basically, we share the same goal, meaning maintain theoretically the overall survival that we have achieved, or at least understand that we may have a loss in overall survival, reduce toxicities, improve quality of life, and reduce cost. And as such, everybody starts speaking about de-escalation, and basically interrupting ADT, the Attard, or both has become a very attractive concept. What I would like to do is to show a few examples, but also highlight some of the caveats in these strategies. First thing you can do, and seems very popular, is say, okay, why don't we stop just the ADT and we keep the patient on the ARPI? I took example from a study that are broadly available. This would be the Libertas study, where in patient with an undetectable PSA, you basically only stop the ADT and you keep the patient on the AR pathway inhibitor. Is it a de-escalation question? I like to call that more an embark question. That does not really pertain to the intensity of drug, but which drug do we use? Is there a potential loss in overall survival? Actually, the only good data we have is EMBARK, and although there was no comparison, everybody seems to pinpoint at the fact that there was a close to 20% difference in the hazard ratio for the MFS. When it comes to toxicity, if you look by the number, there's no difference. In EMBARK, the rate of grade 3 or more is the same in the monotherapy and the combined. And if you look at toxicity, basically what you're doing is you trade off toxicity like hot flashes to gynecomastia. And finally, if you look at quality of life, it is not clear, but there is a limitation that I believe that the quality of life questionnaire, I said that yesterday, are not adapted to that kind of question. So what I try to do for each of the strategy is say, considering the goal are OS, adverse event, quality of life, and cost, what is the likelihood what is the OS risk? There is a risk, EMBARK point at that risk. Is there a potential gain in adverse event? By the number, certainly not. Is there a potential advantage in quality of life? We don't know. And is there a cost saving? No. And I'm going to be picky a little bit, but I like to see this is the de-escalation seen by the pharma company, where basically you don't have a lot of, you don't save a lot of money. The second one is to stop the ADT, to stop the Attard and keep the patient on the ADT. This is the Dutch approach. This is very nice study by Duos in the Netherlands. It's called the APA-ENZA short study, where actually they stop the Attard after a certain period of time. And they look at PSA progression, time to CRPC, and quality of life. Is there a risk, potential risk on OS? Yes, clearly, because that's where Attard have been so good, it's increasing OS. Is there a potential gain in adverse event? Yes, probably, because the adverse event of the Attard are significant. For quality of life, is there, we don't know, and for the cost, clearly that saves cost. And then there is the extreme European approach, which is part of the P6 program. This is revisiting intermittent androgen deprivation therapy, exactly like it was done already 15 years ago. This is the de-escalate study. It is sponsored by the European Union, who actually invest a lot of money into pragmatic and dose de-escalation trial. Basically, we repeat Dr. Hussein's trial, and we do intermittent androgen deprivation therapy. The concept has evolved over time. There are the statistical endpoint, like is it feasible? So meaning, what is the proportion of patients without ADT at a certain period of time? Because if everybody comes back on ADT, your arms are similar. But whatever, the study should start during summer. Is there a potential overall survival loss? That's the never-ending story of the SWOG trial. It's you read the data, and the bottom line is that if you look at Dr. Hussein herself, she said, okay, it's inconclusive. So, but you cannot say there is no loss. So yes, there is a potential OS loss. What about quality of life? There have been other studies. This is a Finnish study that showed that actually during the off period, there was clearly a benefit in overall survival, in quality of life for this patient. So this has yet to be confirmed. So is there a OS risk when you revisit intermittent androgen deprivation therapy? Clearly, is there a benefit on adverse event and quality of life? Probably, and this is the highest cost saving you can imagine. I think that can we do that? I would say no. I think that because that potential OS loss and absolutely unevaluable gain in quality of life, we must do trial from this. There are many trials, as I show you, so we have to test it. However, I would like to point at something which has been evolving in the de-escalate trial. One of the characteristics of the trial is that it was from its inception designed with the patient. So Europa WOMO, the European patient organization, has been part of the development of the trial, because I personally believe there is something which is very strange, is that when we do trial like this, it's we, the physician, who decide what is an acceptable loss for the patient and what is an acceptable gain in quality of life. And many of us are not patients, so we don't speak for them, we speak for us. So what we have started in collaboration with the IMI, it's another European product, and a pharmacoeconomic group in University of Leuven, is discrete choice experiment to better understand what patients expect from this, what would they rate an acceptable loss in OS, and what gain they do expect in quality of life and side effects. This is fascinating because it's extremely complex, but the idea is basically that we would redesign the endpoint and especially the confidence interval on the non-inferiority study based on the patient feedback. Finally, we still have a problem with quality of life. I highlighted that already. Many people use PR25 and QLQ-C30 from EORTC. It's fascinating because actually, if you had read the seminal paper by Aronson, you would have read that it's not good when you use hormonal treatment. PR25 was designed to measure incontinence, digestive complications, sexual function, but not hormonal treatment. So what we did is the same. You know that we don't work with fixed questionnaire anymore. We use an item list. And we took patients who had or not experience on hormone therapy, and we asked them to select the topic that were missing in C30 and PR25, and they actually came with that new item list that's going to be tested in that study. So I think that if we do that, it is the patient who have to decide. Finally, this has been addressed today. I will conclude of this. Is there a role for incorporating modern imaging technology today in deciding who should go to de-escalation? I think that the answer was clear from yesterday. It is no. We don't have neither for PSMA or whole-body MRI a good prognostic signature, so this should be incorporated in the trial, but not used in the clinic. So I think that de-escalation is promising, it is attractive, but we need to test it before we broadly embrace it. Thank you very much for your attention.
Bertrand, so to help us for decision making in mHSPC, we have a fantastic biomarker which is called PSA. At 6 to 8 months, it has a very impactful prognostic value. And we have asked Dr. Marianne Taplin to address whether we can use that for further escalation strategies. Marianne, please.
Thank you very much. Thanks to Silke and Aurelius for another wonderful meeting. They know how much I love being here, so I think I'm going to buff up my diagnostic work and come back in 10 months. And I recommend that for everyone. So here are my disclosures. So PSA, you know, what's old is new. And I was asked to speak on a very specific topic, that is when a patient with metastatic hormone-sensitive prostate cancer is on therapy, which includes hormone therapy, and they reach if they don't reach a PSA nadir of 0.2, should we change their therapy? So I want to start by saying unfavorable PSA decline does not equal progression. And I'll start this talk talking about this PSA biomarker, the history of it, how we got here, and then I'll end with a few of my clinical pearls, if you will, when a patient is in this situation. So Bertrand just introduced this, I guess, really important study because we're still talking about it all these years later, but this is the SWOG 9346 trial, and what this trial was excuse me, patients with metastatic hormone-sensitive prostate cancer were randomized to continuous versus intermittent hormone therapy. And when they got to the 7-month induction of hormone therapy, in retrospect, this analysis was done for patients who reached a PSA of 0.2. And why 0.2? Because we have assays that go much lower than that now, but at the time of the study, that was the assay that was used and the lowest that was measured. So these patients, the survival was analyzed by patients at 7 months who got to 0.2 or less, were between 0.2 and 4, and were over 4. And you can see that this biomarker holds up very well for how these patients did. So then Dr. Sweeney and his team looked at something similar and charted, looked at the PSA nadir at 7 months of ADT on this trial. And you can see with the blue line that, again, it's very prognostic for survival, either with ADT alone or ADT and DOSI, or all the patients shown here. So then going into our next generation of therapy and, this debate about what we could call them, I'm going to call them the AR axis inhibitors. And you can find in the literature the same analyses or very similar analyses for apalutamide and abiraterone, and then there's a whole slate of, I'm going to call wide world instead of real world, because I have a thing with the real world term. But there's a lot of studies here, and this is one that represents them from the Latitude trial, where they looked at PSAs of 0.1 at 6 months or 0.1 at 12 months, and stood up as a biomarker for radiographic progression, overall survival, and PSA progression. So there are unanswered questions about this PSA biomarker, which include, which is the time point we should be assessing. 7 months was what was used in the SWOG trial, but obviously that's not written in stone. Should we be using 12 months? Should we be using the true nadir? And then what is the target? Well, should we stick with 0.2, or many of the assays now go to 0.02, or is there some other number? And how do genomics fit into this assessment? Our patients are all individual and heterogeneous, have very different makeups of their tumor, and should that be assessed in conjunction with a sort of single biomarker like PSA? This is just one slide on genomics, and this is from the Stand Up to Cancer International Dream Team, published by first author Wasim Abeda here. And this just shows that there are, genomic biomarkers that correlate with response, and RB1 and P53 mutations correlated with a very short time of response on AR-axis signaling inhibitors. Okay, what do we do with these patients, right? And I want to just repeat to answer the question I was asked to answer is no data exists to change systemic therapy if your patient doesn't reach an optimal PSA nadir. However, this point in time would be a good clinical trial strategy for randomization at this point. So here are my clinical considerations, sort of the take-home message. I want everyone to be aware that this is an important biomarker, and your patient should be assessed for their response to ADT, probably around 6 to 7 months. And what I would say is if you have a patient in this situation, first thing to ask is the ADT optimal? Check the testosterone level. If the testosterone isn't in the castrate state where you want it, I would suggest testing it in a second laboratory, because I've seen a lot of erroneous testosterone levels. If the testosterone is measurable, then please consider changing your ADT if it's injection, or assessing the patient's if they're taking orals, such as Regulolex. And if they're on AR-axis inhibitors, a lot of time we dose reduce them over time for a variety of reasons. It might be a good point to assess whether a patient could be titrated back up to full dose if they're not having a PSA optimal response. If they were candidates for prostate radiation that hadn't been administered, please consider that. If they were candidates for SBRT to METs and didn't receive that, you could do restaging at this point and reconsideration of SBRT to their METs. If they were a candidate for triple therapy but didn't receive triplet therapy, again, this might be a good time, especially if it's inside of 6 months, to consider intensifying standard of care therapy. If it hasn't been performed to date, I would recommend doing germline testing, because this is a patient is going to be considering other therapies, probably in the short term. And similarly, if you haven't done somatic testing, either on the original biopsy tissue or a new metastasis biopsy, this is a very good time to get that done. And then I think, as Bertrand just noted, the importance of patient input into their care. I think if we have patients who are receiving suboptimal PSA naders, because often the patient's PSA goes down from 60 to 5, and they're really happy, and we're kind of like, oh my goodness, like, we know what's coming. So I think, like, educating the patients and sharing your concerns and share decision-making for what are the optimal repeat PSA schedules and reassessment schedules. So in conclusion, PSA nadir is prognostic for RPSF and OS. PSA nadir is not a validated endpoint to change systemic therapy. Recognition of suboptimal PSA nadir is an opportunity to evaluate if all available standard of care treatment options have been maximized. And recognition of suboptimal PSA should prompt careful consideration of the patient's future assessment schedule. Thank you very much.
Thank you very much, Marilyn. So not only we are discussing whether we should further intensify or de-escalate treatment, we are also changing the rule, the basic rules about how we assess the disease with imaging. And many of us are currently using PSMA PET. So we've asked Dr. Dana Rathkopf from New York to try to address how to deal with patients who have apparently low volume disease by conventional imaging, but high volume disease by next generation imaging. Dana, please.
Great. Thanks so much. I'd like to thank the organizers for asking me to speak today, and a special thank you to Aurelius and Silke, who put their heart and soul into this conference, and it shows. So thank you for that. So it's going to take me all 10 minutes just to read my topic. How to manage patients with low volume disease on conventional imaging and high volume on next generation imaging. These are my disclosures. So we've heard quite a bit over the past 2 days about clinical risk groups and treatment selection, and you can tell already it's already complex as is, and now we need to incorporate next generation imaging into the current treatment paradigm. So the clinical conundrum of PET imaging for initial staging and treatment of metastatic hormone-sensitive prostate cancer includes a lot of pros. There's increased accuracy relative to conventional imaging. It's better at detecting small lymph nodes and early lytic bone disease, even at low PSA. There's potential for targeted treatment options based on imaging results. But there are also, I'm not going to say contraindications, but considerations that we need to think about. Indeterminate findings can delay treatment and cause patient distress. And this is really important to think about in this population, because a lot of patients are going to be diagnosed for the first time with metastatic hormone-sensitive prostate cancer, and they're trying to understand their prognosis, their extent of disease, what's coming, what their treatment options are. And when you have discordant imaging findings and additional tests that need to happen, and this delays a treatment plan, it can be really stressful for patients and stressful for us as clinicians trying to adjudicate these findings. We don't really know what the importance of PET-only metastasis is unclear. So if you have conventional imaging occult lesions, but lesions on PET imaging, what do those lesions mean? Are they indolent, perhaps? Or maybe they're a harbinger of something more aggressive to come, and you need to escalate therapy. And really, at the crux of all of this is, do PET-directed treatment decisions lead to better clinical outcomes? So this was an interesting multi-center international study that was retrospective, but it looked at clinical and genomic differences between metachronous oligometastatic hormone-sensitive prostate cancer, and they broke the patients up into imaging, conventional imaging, where you could see metastasis, and PET-only imaging, where you saw metastasis. And what they saw was that on the PET-only metastasis group, that there were fewer high-risk mutations and better survival. And this is food for thought today in the context of this talk, because it makes you wonder, can we extrapolate this concept of PET-only disease potentially being more indolent to the polymetastatic setting? So, it's important to point out, and we already know this, that the prognostic clinical subgroups are very helpful, but they're not one size fits all, and this is true more so than ever now that we have next generation imaging. This study on the right was looking at patients that had had conventional imaging and PET imaging, and what you can see is that 40% of patients that had low volume on conventional imaging actually shifted their subgroup on PET. And I'm going to point out that they not only shifted their subgroup up to more aggressive disease, but also down to more localized disease. And so we need to be very, very cautious when trying to retrofit PET findings into conventional imaging-defined volume subgroups. A high-volume PET imaging patient might not be a high-volume conventional imaging patient in terms of prognosis. And I think the STAMPEDE 2 trial illustrates this nicely. I appreciate that they're using different terminology for the PET imaging, oligometastatic and polymetastatic, and I think this helps in terms of confusion in terms of prognoses. Calling a high-volume PET patient is, as I mentioned, is not the same as conventional imaging, so I very much favor this oligometastatic, polymetastatic terminology. And this is just one example of multiple studies that we've seen over the past several days that are trying to incorporate next generation imaging into the study design so that we can better understand the natural history and how it impacts outcomes. But in the meantime, many of us are going back to clinic next week, and we are going to be seeing patients that have discordant imaging, conventional imaging low volume and PET imaging high volume. And even in our own APCCC conference in 2022, we were split pretty much down the middle as to how to manage this. There have been other consensus groups also giving guidance, such as treatment should not be changed based on next generation imaging findings, or patients should not be denied radical local treatment solely because of metastatic lesions on NGI. And in principle, I agree with this, but in practice, it's much more difficult. So here's an extreme example. This is a patient with low volume disease on conventional imaging, 58, newly diagnosed, fit, Gleason 9 prostate cancer. Reasonable minds might differ on the treatment path here, and that's fine, as it should be. It's not one size fits all, as I mentioned. But more or less, if you were going to treat this patient, I think certainly androgen deprivation therapy and androgen receptor pathway inhibitor. Personally, I probably wouldn't use docetaxel unless I had some more compelling evidence, because there is limited data for this low volume or immature data for this low volume group of patients. I would certainly think about prostate radiation therapy and plus or minus metastasis-directed therapy. I think we all do it in our clinics, and that's fine, but we don't really have a lot of good prospective data for this yet. But this is what this patient's PET scan looks like. Imagine how the patient feels, and for us, it's very confusing. We can't ignore this finding, and we shouldn't ignore this finding. But how does it affect our treatment plan? Well, for me, I would still use androgen deprivation therapy and an androgen receptor pathway inhibitor. I think there's good data for that in all stages of disease. It might make me think a little bit more about docetaxel. I mentioned that there's limited and immature data, but not no data for low-volume de novo disease. It would certainly make me think a little bit more about whether or not to use prostate radiation, but we've heard quite a number of talks yesterday talking about radiation to the prostate for local control as an option. And it probably would lead me against doing metastasis-directed therapy. We know the STOMP and ORIOL trials that did incorporate PET imaging showed that if you leave lesions behind, that doesn't really help the patients. So in conclusion, general principles for treating metastatic hormone-sensitive prostate cancer in the burgeoning age of PET imaging. I think that clinical subgroups should guide but not decide treatment decisions. I mentioned that treating metastatic hormone-sensitive prostate cancer is complex in the beginning, and it's complex not just because of our treatment selections, but also because of the patients. Patients are complex and bring their own history and their own preferences to clinic, and we need to honor that in our treatment decisions. I think we really need to be careful about terminology for PET findings, especially when they're discordant. I favor oligometastatic and polymetastatic as opposed to high-volume PET, low-volume PET. I feel that's confusing. And finally, PET imaging is just one piece of the treatment puzzle. Use caution, because what you see is not always what you get. And so for us, the metastatic hormone-sensitive prostate cancer treatment puzzle, if you will, there are many pieces. Our challenge is to put them together so that we can see the big picture and treat our patients best we can. Thank you.
I'm mesmerized by Dana's slides. Those are great. It's my pleasure to introduce Chris Sweeney. He's going to talk to us about the management of patients with metastatic hormone-sensitive prostate cancer and early progression on combination therapy. Thank you, Chris.
Thank you very much, Mary Ellen, and thank you, Silke and Aurelius, for this amazing opportunity to share some thoughts. And first of all, just to get the disclosures out of the way relating to advising and research, as well as being the PI of the Chartered Studies, Enzymet studies with Ian Davis, which may influence some of my thinking. My assignment, how to manage patients who have early progression after 6 to 12 months of combination therapy, and by that, testosterone suppression with ADT plus abiraterone and enza-darolutamide, may have had docetaxel, may have had radiation to the prostate. How do we deal with this patient? So first of all, how do these patients fare? The frank answer is we don't have enough data yet because we haven't got all the individual patient data from all the clinical trials saying, how did the patients progress after they had a PSA that went down, then came up 6 months later. We don't have that data for abiraterone and the amides yet. So it's a plea for us to be able to do individual patient data meta-analysis to really get good granular data through the stopgap. We've done it with the ADT without docetaxel. Now we need to do it with the advanced hormones. We've got it for all the cooperative groups. Piece 1, SWOG, the arterial, Enzymet and Chartered, Stampede, but with a plea for pharma to be able to help us access the data into that stopgap repository. But this is what I can say from Enzymet. If you don't have a PSA progression during the follow-up, we've got 92% of patients alive at 5 years, and 8% of patients are dying of something else. And it's about 392 at this stage, with some still in follow-up who had not reached the 5-year mark. Black are patients who have PSA progression and then radiographic progression with a 42% 5-year survival, and 34%, 10% of the patients, purple, who had radiographic progression without a confirmed prior PSA progression. Some of them neuroendocrine, some of them anaplastic, but they do the poorest, as we can see here. Early enzalutamide decreased the rate of all types of progression. And the hypothesis is that the 5-year overall survival would be even worse for the patients who had early progression with enzalutamide because they didn't have the salvage opportunity with an amide for castration-resistant disease after ADT alone. We would look into that for the publication. But this, I think, does make an argument for some degree of surveillance, following on from Michael Morris's talk yesterday, and it would be great to also get this data from Archers, and we can actually see when and how often these patients were progressing, what were their features, and define a surveillance strategy with imaging in addition to PSA, even if their PSA is low. So, it is imperative to define the best first-line therapy option for each individual patient. There is no single therapy that is best for all patients. Patient and tumor profiling is key, so we can precisely deploy precision, targeted, personalized medicine, whatever term you want to use, we need to actually find the right therapy for the patient. And our goal is to use as many life-prolonging therapies as possible, but we need to use the best one up front. Many patients are not able to go from first to second to third line. We just look at the PSMA-4 study, 15% of patients didn't get to cross over to the alternate to the early lutetium PSMA after their hormone switch. And that was a highly selected patient population in a clinical trial who were thought suitable for a hormone switch. So we need to get the best first-line therapy. So how do we do this? And I say it is imperative we do proper profiling. Patient characteristics: have they had docetaxel? Have they had radiation to the prostate? Are they suitable for docetaxel or cabazitaxel in the castration-resistant setting, if cabazitaxel being if they have had docetaxel for hormone-sensitive? And what access do you have in a given region? Lutetium PSMA is not available throughout the world, for example. And what are the tumor characteristics? I would say when this APCCC world where we get access to all therapies, we PSMA PET CT profile patients, tumor exome profiling, focusing on BRCA1 and BRCA2, and MSI, and the tumor suppressor gene mutations, P53, RB1, and PTEN, for the reasons that we saw in the talks yesterday from Matthew Smith and what Mary Ellen presented. And what's the extent of their progression? Is it oligo or diffuse progression? And here is our patient who's been on hormonal therapy for a while. He's not the fit Superman in his 50s, like Karim Fazazi. Oh, you're in your 40s, sorry, Karim. Sorry, aged you. But look, he's a little older, he's a little frail. He's happy to see you because most of our patients are charming. But we want to do the best. This is a picture from the Google, but I thought it matched. He's been on hormonal therapy, he's got the central obesity, so he's not super fit. Has he got oligoprogression? Can we possibly think about external beam radiation? PSMA PET high. What is the optimal high? SUV greater than 10, we've got some data for that I'll talk about. No discordance. Maybe lutetium PSMA is an option for him. Germline BRCA or somatic BRCA1/2 mutation, a PARP inhibitor. Loss of 2 or more suppressor genes, carboplatin and a taxane, there's data for that. And none of the above. This old drug called docetaxel, cabazitaxel, it has a survival benefit. If you resort to it, it's not that they are getting an inferior therapy, it's just older and it's not talked about as much. But it's still a therapy that we should be considering. And for the immune therapy, the one data set that I think is very strong that we should think about is if MSI high, consider a PD-L1 inhibitor, although the data is very limited. So first of all, what's the data for oligoprogression and stereotactic radiation? Here we have a multi-institutional study, small numbers, and what you can see, if you can do complete ablation, black curve, you've got 40% of patients who are still on therapy and didn't need an escalation with SBRT alone by 18 months. That's an option for these patients. This could also possibly include, as Mary Ellen alluded to, radiating the prostate if they're having some growth of their prostate and no other progression on scans. And again, I think this makes a case for surveillance imaging to see oligoprogression. Well, what's the optimal patient profile for lutetium PSMA? Well, we know that lutetium versus cabazitaxel for the therapy study, no real survival benefit. They're both good therapies, but when you drill into the data, the patients who had a high PSMA SUV mean greater than 10 did better than the cabazitaxel by radiographic progression and PSA progression. So maybe if there was a more biomarker selected, we'd actually see a survival benefit with lutetium PSMA versus cabazitaxel. In the VISION study, where lutetium PSMA was compared with non-life prolonging therapies for castration resistant, there was a clear survival benefit. And again, the outcomes were best for those who had a PSMA PET SUV mean greater than 10. So I would direct a patient with high PSMA PET imaging to lutetium PSMA. However, if they have a BRCA mutation and a low PSMA PET, with the PROfound trial and the long-term follow-up that was just published in the JCO shows that there's a clear survival benefit for a PARP inhibitor single agent in this setting. Biological, targeted precision medicine at its best. But if they are biomarker negative, no indicative biomarker, let's look at history here. Greater than 90% of the patients on the TAX-327 had 2 or more hormone manipulations for castration-resistant disease. And we know mitoxantrone and prednisone was better than prednisone alone in quality of life, and docetaxel prednisone was greater than mitoxantrone and prednisone for quality of life. And there was a survival benefit. Let's not forget about docetaxel. We're not giving them patients inferior therapy because we don't have the new fancy therapy. It is a therapy we should not forget about. And to cabazitaxel after docetaxel, again, compared with mitoxantrone, there's a survival benefit. I can't say that for a PARP inhibitor for a patient with the non-BRCA HDDRs, as clearly as we can see here for cabazitaxel. And because we didn't believe it the first time, we did the study with a hormone switch, and we again see a survival benefit. So, what about the patients who have this terrible prognostic disease, anaplastic variant, sometimes a small cell, sometimes neuroendocrine, and they tend to have 2 or more mutations in P53, RB, and P10? Do we have a therapeutic option for them? And the MD Anderson team, with Anna Aparicio representing the team here today, published this really well-done study that read you had a survival benefit if you got a platinum with the taxane versus just the taxane alone. Randomized phase 2, but it's the best we have. And trial is a misspelling. That's not my Italian of trial, trilla. It should be trial, so apologies for the typo there. So the Memorial Sloan Kettering has a great project of profiling their patients with their IMPACT exome next generation sequencing panel. 2% of patients have MSI high, so it's worth checking, but it's very rare when you're also checking for BRCA and the tumor suppressor genes. 11 of the patients actually had PD-1, and notably, 5 of the 11 had meaningful responses, with some lasting more than 89 weeks. So, the profiling imperative for maximal patient benefit, oligoprogression, think about external beam, PSMA PET, lutetium PSMA, germline BRCA, somatic BRCA, PARP, loss of 2 or more, carboplatin taxane, none of the above, docetaxel or cabazitaxel, MSI high, maybe a PD-1, PD-L1 inhibitor in the future. Thank you very much. We can do this.
Thank you, Chris. That was super. Next, I'd like to introduce Maria DeSantis, and Maria is going to talk to us about management of frail patients with metastatic hormone-sensitive prostate cancer.
Thank you very much. Good morning, everyone. I would like to start with thanking Silke and Aurelius for having me here. It's a great pleasure and honor to be part of this outstanding conference. Thank you. So my topic, frail patients with mHSPC. These are my disclosures. And I would like to start my agenda with the definition of frailty and looking into the life expectancy. So it is well known, but maybe underappreciated, that age itself does not necessarily come with geriatric conditions or a frailty. However, we are treating with frail men, and frailty most likely comes with age. So we are talking about the decrease in physiological reserves of multiple systems, which increase vulnerability to stressors. So the definition of frailty is based on 5 components, including nutrition with unintended weight loss, energy, physical activity that can be self-reported or measured with grip strength and slow walking speed, physical strength, difficulty in lifting bags weighing 5 kilo, for example, and mobility, difficulty in walking up and down stairs. When the patient meets 3 or more of these 5 components, the definition of frailty is met. If it is only 1 or 2, the patient is pre-frail, and this makes a huge difference in the life expectancy. As you can see here, depending on the databases and the literature, the median life expectancy of a frail man, and I say man because it is more in women, but frail man 1.2 years, but pre-frailty brings a life expectancy of 6 years, so a huge difference. And we should keep that in mind. There are more sophisticated tools, and I made the exercise of putting 3 frailty points and some comorbidities into the UCSF e-prognosis calculator, a mixture of Schoenberg and Lee index. I don't go into details here, but the Lee index told me that this patient would have a life expectancy of 3.8 to 5 years with 3 frailty points and some comorbidities. So it makes sense to look into some detail before taking treatment decisions. So how do we achieve the diagnosis of frailty? So this is a graph out of educational booklet of ASCO last year, led by Alicia Morgans, a great graph showing that we start with a geriatric screening tool. The G8 tool is recommended by the EAU guidelines. If we find abnormalities, the cutoff is 14 points here. We should, I think, look into our resources. I would not have the resource for going into comprehensive geriatric assessment. However, if we find intervenable areas, we should intervene and treat them if possible. If there are non-intervenable areas and the patient is diagnosed as frail, we should look into non-cancer life expectancy, as I have shown you before. And of course, the goals of the patient, this should all be patient-centered. And most importantly, early integration of palliative care is not only recommended by the ASCO clinical practice guidelines, it is a mainstay of our treatment in these patients. So my clinical perspective here, my personal view is that even though frailty is regarded as a potentially reversible condition, in mHSPC management, I think we don't have time to wait, putting patients on waiting lists for assessments and then wait if those measures would help or not. We need to take our treatment decisions now. So what about the efficacy of treatments in frail patients? We don't have data. The EAU guidelines tell us that we should offer ADT monotherapy only in patients that have a life expectancy of 1 year or less. All the others should be offered a combination therapy. So you have seen this curve, I think 12 times already in this meeting, sorry for that. ADT alone is effective, but it is not that effective in de novo high volume disease, for example, with 3.5 years life expectancy. It is much more, up to 8 years in other patient groups. Maybe this is not the endpoint, OS endpoint, that we need so much in this patient population, but in the same paper we find the time to CRPC maybe reflecting the time the patient is stable in a certain state on treatment. So, and here we see that ADT alone only allows 12 months of time to CRPC, and this is 2 years in the low volume metachronos patient population. So this is maybe not so much if a patient has a life expectancy of 3 to 4 years, for example, even though he is frail. Efficacy of treatments, we have data on younger age and older age. Docetaxel is working very well in both age groups, but of course we would never think of using docetaxel in a frail patient. Looking into ARPI-based combination systemic therapies, we find that younger age patients are benefiting a lot. Older age patients are benefiting also, but maybe to a little bit lesser extent. But this is not data in frail patients, admittedly. So how can we achieve the individual patient's goals? Can we select appropriate treatment and treatment intensity? So a given patient, 84 years, frail with 3 or 5 points, with mHSPC de novo high volume and mild symptoms. He has a natural life expectancy of 3 to 4.5 years. 7 CONMETs, including clopidogrel for atrial fibrillation and stroke in the past, hypertension, some mild diabetes. So what I want to point out is that frailty rarely comes without polypharmacy and drug interactions. And the intake of 5 to 9 medications brings along a 50% chance of an adverse drug interaction. So drug interactions are a problem for our patients, I think. So drug interactions are frequent and potentially also harmful and might be life-threatening. Clopidogrel, together with a strong inducer, might make the drug ineffective and cause another stroke, maybe. So in such a situation, ARB-PrET would be preferred option over ANSA, APA, or darolutamide, for example. But what are the patient's goals? The patient tells me he wants to have the symptoms improved, yes, no deterioration over time, and maintaining quality of life. Can we achieve that? Well, the options are pretty obvious. We can give ADT, of course, and with a life expectancy of 3 years, add an RP, ARB-PrET, APA, ANSA, and of course we should never forget about palliative radiation to bone or prostate or whatever indicated. My last point is interventions. We should not leave the patient alone with a shot of Lupron. We need interventions to improve the tolerance of treatment and quality of life. And this starts with the first shot of ADT. We need to look into bone health management and also in frail patients that start on ADT, indications for bone anti-resorptive therapy along with vitamin D and calcium. The risk of falls is an important topic. We should consider physical therapy, referral, and on strength training, also for patients only on ADT. If we consider combination, abiraterone or darolutamide might be preferred in lieu of apalutamide or enzalutamide when it comes to risk of falls, for example. And when the focus is on cardiovascular health, we might consider the use of LHRH antagonists in lieu of LHRH agonists, for example, together with optimizing cardiovascular risk factors. So in summary, we should explore the frailty status and the life expectancy of the patient to start with, and of course the goals of the patient. ADT alone in patients with a life expectancy of below 1 year is fine, but with continuous supporting interventions that are crucial, physical training, osteoporosis prophylaxis. LHRH antagonists if cardiovascular health is a priority. We should consider the addition of an RP in other patients that have a longer life expectancy. The selection is dependent, of course, on the side effect profile of the individual drugs, which you all know, the risk of falls and potential drug-drug interactions. And we should never forget about early palliative care involvement. Thank you very much.
Okay, and last before our discussion, Dr. Gerhardt Attard, who will talk to us on future changes in the setting of metastatic hormone-sensitive prostate cancer.
Silke Aurelius, thank you for the remit. It's possibly the exam question everyone wants to get. Nice clean slate. I draw your attention to the bottom of my, I guess, non-financial disclosures that are relevant to this talk. So I split my talk into two, treatments and biomarkers. What does the future bring? And I've got 10 minutes to cover the future. What the future certainly doesn't bring is immune checkpoint inhibition for unselected patients. I hope we'll develop a way to use the immune system to treat our patients, but clearly there's no scope for unselected patients. So looking through clinicaltrials.gov, I identify a number of randomized pharma-sponsored trials. Pleasingly, we're seeing patient selection for the majority of them and biologically based patient selection. So AKT inhibition for patients with a PTEN deficiency as ascertained by centralized IHC score. PARP inhibitors for patients with deleterious alterations in BRCA2 and a few other genes involved in homologous recombination repair, Lu617 for PSMA positive disease, and then I guess I emphasize on these because the estimated primary completion date is coming up. They all started randomizing in the past 4 to 5 years, so expect in the next APCCC we're going to have data for these trials. One thing I'll emphasize, however, that the future is not here yet. I'm not going to disclose the voting, Aurelius, but this was one of the questions we were asked, and I believe strongly we should not preempt the results of trials. We were asked whether we would introduce a PARP inhibitor for a patient who's found to have a BRCA alteration. I don't think we have that data yet. I guess more to discuss later. So now I'll talk to 3 challenges, considerations that will come across, be faced with, as these trials report. And the first is the primary outcome measure. All the trials I listed have rPFS as the primary outcome measure. Overall survival is a secondary endpoint with a time frame for follow-up of about 48 to 80 months. These trials have not been pre-powered to detect a significant benefit for OS. I think that could come with some challenges that we need to think about, some considerations. So first, Susan Halabi's recent work showing that rPFS is a reasonably good surrogate of overall survival for patients starting ADT or ADT docetaxel. So this is upwards of 6,000 patients, but I'll draw your attention to the recruitment period for these trials, which ended over 10 years ago. About 30% had ADT plus docetaxel. And interestingly, in all these trials, rPFS was defined by the investigator, did not require confirmatory lesions or additional lesions as required by PCWG3. So as you see in the graph, the y-axis is the 5-year overall survival rate, and x-axis is the 3-year rPFS rate, and the circle size refers to sample size. So some considerations. mHSPC therapeutic trials are effectively a test of early versus late, at least for the effective therapies in that list, PARP inhibitors, Lu617. So showing an rPFS benefit doesn't necessarily mean using that treatment earlier is going to improve survival. What we would expect it to do is increase toxicity, increase exposure. So we need to be careful about that. The second is the surrogacy data has been established in, as I said, ADT docetaxel, and we need to be cautious about extrapolating that to drugs with a different biological mode of action. Now this, of course, is the chicken and the egg. We want to use surrogates to show efficacy for new drugs, and those surrogates have been developed for old drugs. But what we can certainly do, and I know this is ongoing, and Chris already intimated to this, surrogacy analysis using ADT and the RSIs, and we have the data, or StopCap have the data from academic studies, but we really need our pharma partners, especially, a call out to those in the room to increase access to the pharma trial data. And I think we really need that, to understand. I guess what I didn't point out, but it's been mentioned so many times over the past day and a half, the backbone for all those trials was ADT plus ARSI, and that analysis was done in patients, none of whom received ADT ARSI. So the second challenge is patient selection. This is data we published last year, which is the this is failure-free survival for patients in STAMPEDE, randomized ADT versus ADT abiraterone. Clearly, abiraterone is effective, all ARSIs are, and there's a notable proportion of patients who do not progress. When we closed the trial about a year and a half ago, a quarter of patients continued abiraterone with no evidence of progression. So those patients do not want to go in our trials, and we do not want to treat them in our trials. How do we identify them, and how do we interpret that data? I don't have an immediate answer. I'll come to that later. There's a number of prickly questions that the PEACE program is looking to identify, including, should we use darolutamide in vulnerable patients? Should we treat oligometastatic disease with SABR? Do we de-escalate? Bertrand's already talked about this, and that's especially pertinent given the previous slide. And one thing I'll add to that information is that whereas on ADT, the majority, over 95% of low-volume metastatic patients die from prostate cancer, on ADT abiraterone, it's about 70%. So 30% of patients, at least in the low-volume group, are dying of a competing cause. In the high-volume group, it's about 15%. And the last point that Karim referred to earlier was, how do we treat, or can we intensify treatment using PSA? So the third challenge, treatment sequencing or overlay. So this cartoon, if we use triplet or quadruplet therapy, Nick talked about triplet yesterday, I won't go into that, but clearly if all the trials on that first slide are positive, we're going to start to face the challenge of a year and a half of aggressive treatment with further combinations going forward. We're trying to, or we will be addressing some of these challenges in STAMPEDE 2, which has started. This borrows a lot from STAMPEDE 1. It's a multi-arm design, but restricted to metastatic patients, primarily because the high-risk non-metastatic now have such good outcomes. The prostate cancer-specific death rate for those M0 patients we discussed yesterday is 7%. So for metastatic patients, they're divided into oligometastatic, and if they're oligometastatic, can they have SABR, in which case they are randomized to receive SABR or not. If the SABR ineligible or polymetastatic, they're then offered randomization to LU617 or not. All patients undergo next generation clinical testing for BRCA2 and a few other HRR genes, and those who are positive are randomized to niraparib maintenance therapy. And of course, there's the backbone of ADT ARSI, and we also allow docetaxel, and of course, we'll stratify by intent to use docetaxel. So on to biomarkers. I think we need prognostic tests to inform on that intensification, and then we need predictive tests to work out who will the drug work for. And I'll focus on docetaxel, which is a question, a problem we've been looking to interrogate for 5-6 years now. So to discover, validate, and then clinically implement a biomarker, we need large data sets with prospective follow-up. We need to use a test that works on the challenging tissue we have access to, so it has to be fit for purpose. To ask a predictive biomarker question, we need randomized patients, and of course we need, well not of course, but we certainly need large numbers of events to prove a statistically significant interaction between the biomarker and the drug. And we need cross-validation across trials. And really the only way to achieve this is cross-consortia collaboration, which necessitates using a test. There's a number of approaches that are being developed. The one which is really leading the pack currently is transcriptome-wide testing in collaboration with Veracyte. This cartoon shows the flow. There's the ITT population. We collect blocks from about 40 to 60%. Then tumor areas are macro-dissected. The ctDNA is hybridized to microarrays. We get data on 40,000 genes, extract signatures, and then we can start testing for associations with outcome and subsequently prediction. So the Chartered trial provided really intriguing hypothesis-generating data. Matthew Smith presented this yesterday. And then based on that, we proceeded to study the Stampede abiraterone trial. Again, Matthew presented this data, so I won't present it again, and it's in a preprint referenced at the bottom. And now we've proceeded to study the Stampede docetaxel trials and work on enzyme metastasis. So we're going to have thousands of patients, or tumors from thousands of patients, all analyzed with the same test that I hope will allow us to achieve those 3 targets in my title. Finally, artificial intelligence-derived models on digitized histopathology images. The advantage here is that the resource is not finite. We can work with multiple partners. This is data from Stampede, working with Artera AI. What this multimodal model does, and it includes digitized images, T-stage, age, PSA, and Gleason score, is prognosticate. And how can this be helpful? So I'll really draw your attention to the gray box, and this is the M1 low patients. The numbers there are the 5-year prostate cancer-specific mortality estimates. In brackets is 95% confidence intervals. And you can see for a low-volume patient, we can distinguish one who has a 90% chance of prostate cancer death at 5 years versus 37% for the bad Artera AI prognostic group. So to conclude, I think, or I hope, we will have positive phase 3 trials. That's for RPFS. I think that will change practice, but we will need to follow up patients to show an OS benefit. And I'm confident we will be incorporating biomarkers to guide docetaxel use. Thank you.
Very good. Thank you, Gert. Now we have about 10 to 15 minutes for Q&As. Please feel free to come to the mic. I see already a question, please.
So Anthony Joshua, Sydney, Australia. Question for Bertrand. So you have been talking to patients about the de-escalate study. Janssen are jumping up and down to say they've also been talking to patients and they're very happy to be randomised to an arm that gives them a 50% rate of gynecomastia. Isn't the best study the one that the patients get to choose what they get to de-escalate with? So we're still possibly in the wrong mindset completely. What we should be saying to the patients is, your PSA is 0.01. We think it's appropriate to de-escalate. Which of these 5 strategies do you want to de-escalate with, if any at all? Because a large proportion of patients will say, no, thank you. So I just put into you, and perhaps also to industry, that we've got this patient input completely backwards. And we should be asking the patients what they want to de-escalate to.
So when you speak to patients, they can only answer to questions you ask them. Okay, so if you ask them, would you stop the ADT? They're going to say yes or no. If you say, I'm going to stop everything, they're going to say yes or no. The whole idea about the discrete choice experiment project is to put in place a system where we can assess this question with the patient, okay, and ask them what is valuable for them. And in the work, it's done by a young PhD. All these questions will be addressed. So trying to say, okay, what's the toxicity of ADT? What's the gain of stopping ADT? What's the toxicity of an AR pathway with ADT and alone? And so we can better understand exactly what you say, which one stop. Then there is something interesting, is that if you ask them to choose and you've not prepared well, what could be the theoretical consequences of the choice, they may choose by their own experience. If they experience toxicity, they're going to stop. If they worry about overall survival. So I think it's an extremely complex field. There are 4 strategies, as you said, and I mean, we thought about that. Initially, we thought about doing the multiple arms trial, but then it's becoming extremely complicated to randomize because basically you introduce a patient selection, and you would expect patient with a more favorable response and no toxicity to keep on the drug. So that's why we understand it's much more complex. We don't understand fully the complexity, and that's why we chose, okay, industry is doing an approach, we're doing an approach, and in the end, we're going to try to understand better what is there for the patient. But it's extremely complex. But I agree, in the ideal world, we should ask them, pick up, but what is the consequence of your choice? We don't know, because we don't have the data.
Could I comment as well? So Stampede 2, we thought about randomizing patients to stop or not, particularly in the low-volume arm with SABRE. And in the end, we decided it wasn't feasible to power it up and stuff. But what we have written into the protocol, particularly on the basis of the ABI M0 data, where if you look at the survival, these are clearly low-volume M1s, had we done PET scans and stuff on them. And they only had 2 years of therapy, is the option to stop at 2 years. And that option will be the patient's, not as much as ours. So I think that is an alternate way of testing. I'm sure it's open to criticism, but I think it seems reasonable, because I think in the oligomets arm, we're effectively testing the question, can we cure patients with low-volume metastatic disease? And I think we probably can cure some of them. We really don't want them on ADT for the rest of their lives, which are going to be very long, even if they're not cured.
Maybe a follow-up question from online. Dana, I will direct this one to you. So what about rescanning patients at 6 months? And because you talked about PSMA PET, any radiating remaining lesions in case of a detectable PSA? Is that something you're doing in your practice or not? Or would you do it?
So I find it challenging to re-image. I mean, for the population that I was talking about, the metastatic hormone-sensitive prostate cancer patients, they're starting treatment, and usually they're responding to treatment, so their PSA is undetectable. And my understanding of next-generation imaging, and particularly PSMA PET imaging, is that it's dynamic study. So if the patient is responding and the PSA is undetectable, I don't know what the value is going to be for subsequent imaging. We heard, there's some question about whether AR inhibition can actually upregulate PSMA, so maybe we'll see, worse, or I think Michael talked about flare. So it's complicated, I think, re-imaging with next-generation imaging, and it's, something that people are looking at. But I tend not to re-image with PSMA PET when a patient has an undetectable PSA.
All right. Niraj and then Dan, please, short questions, short answers.
Yeah. Bertrand, excellent talk on de-escalation. Just a very quick question on use of GnRH agonist versus antagonist when we are pursuing de-escalation approaches. I still remember some patients from SWOG 9346 trial when we were checking testosterone level on GnRH agonist like leuprolide, testosterone sometimes won't recover for months to years. So just a thought whether we should ideally be using GnRH antagonist for de-escalation trials.
So one of the requirements to make that study feasible is that it's run as a pragmatic trial. So basically, this is randomized real-world evidence. So meaning people, and we're going to capture the data. So the main biomarker we will capture will indeed be PSMA, so that's a lapsus. Yeah. PSA and testosterone. And that's why also we had a lot of discussion, how long should we keep these patients before we stop? That's why we put the maximum duration of 12 months, because beyond that, we may have a lot of patients never recovering their testosterone. And then our study will be similar to the Dutch trial where they only stopped the AR pathway inhibitor. And that's why in that trial, we will exclude the patient Nick was mentioning, where we believe we have an intention to cure. So, but that testosterone, maybe one day we're going to use oral antagonists to everybody, and we're going to reduce the the variation around testosterone recovery, but indeed we will measure that because that's one of the difficulty when we, and the correlation with quality of life will be interested as well.
Thank you.
Dan, please.
Yeah, so quick question on the quality of life measures. You brought this up, the limitations in terms of interpreting these specific to hormonal therapies, and it's absolutely true. The biggest concern our patients have is the fatigue, muscle loss, the deconditioning. How important is it for us to characterize and collect data on level of activity in our patients in order to put that longitudinal PROM into context? Because as these testosterones recover, patients don't feel better from testosterone alone. They have to recondition. And it's only the patients that are active that are going to feel any difference. But we don't collect. How important is it in these studies that we collect some level of activity to be able to really focus on the patients that can recover?
In the new item list, they will be adding very basic question about level activity, but as you understand, it is very unprecise. And you remember when we did the quality of life analysis on the relugolics, we see a totally different effect between patients who had a high baseline quality of life and those who had a low baseline quality of life. So this will be collected, but once again, in a pragmatic trial, you cannot ask like a physical test, but I fully agree with you, we need to collect this data.
Gert?
I have a follow-on question for Bertrand on the de-escalate trial. It's clearly the prickliest bush in the garden. The primary outcome measure, I think I saw that it is time off treatment. Is it a time of treatment? Do you measure that from testosterone recovery?
So, once again, pragmatic trial, we have to go for pragmatic endpoint. The first and most important endpoint, which is it feasible? So the statisticians have calculated that if you have more than 30% of the patients that are backed to hormone therapy within 1 year of stopping the treatment, arm B will be in any situation equal to arm A. So that's the first one. The second one, we wanted to choose a very pragmatic endpoint that was time to starting the next overall prolonging agent, okay? So assuming it's a large trial, you're going to have validation. Then because of the regulation in the EU, you need to have a landmark analysis for overall survival at a very short interval, 3, 5, 7 years, to be sure you're not heading into a wall in terms of killing patients. So that's why it's a regulatory endpoint imposed by the EU system, is to be sure we don't kill patients. So we need to provide a landmark analysis at 3 years.
Maybe let me take a few questions from online to you, Gert. In hormone-sensitive aggressive variants, do you recommend or use sometimes early use of cabazitaxel plus carbo in contrast to classic triple therapy?
I mean, we don't have the data for that. I think we don't have enough data to be certain that all aggressive variants are going to do badly. So there's a group of patients there who may have long responses. I feel quite uncomfortable treating them with carboplatin extra treatments in that way.
Several questions about the practical timing about stopping ADT in patients with mHSPC, and I'm sure we will provide 10 different answers, but maybe Chris, what do you do in your practice? Do you sometimes stop ADT in patients without major side effects? And if so, when do you consider that?
My number is 2 years, based on if it's a patient who's had some very good response to therapy, micrometastatic disease of sorts, we know we control with 2 years better than 6 months in the adjuvant setting. So patients who are at 2 years with a completely undetectable PSA, scan negative, I say to them, would you like to consider stopping? I don't demand it. I see where they stand about it, saying there are some risks, but if there is a concern and your PSA goes up and your testosterone's gone up, we'll restart the therapy. So, and I've had a number of patients who've been off therapy, and we've all got these anecdotes now after SBRT for low-volume disease, oligometastatic, who are off therapy for many years. And how can we really collect that data? And it sounds like the Stampede 2 will help us get some prospective data, but we need thousands of patients to be able to see how many we actually do cure in that manner. My number's 2 years. Could be wrong.
Gert, a question to you about the potential use of cell-free DNA for monitoring during the break. If we stop ADT or systemic treatment, do you think it has a future as compared to simply monitoring PSA or other things?
Intriguing. I'd love it to. Half my lab works on ctDNA, but I think beating PSA for a patient who has stopped ADT, who has an undetectable PSA, so just a slight rise, it's going to be hard to do that, and especially given the cost of PSA versus ctDNA analysis.
And maybe a last question, which was to myself. Someone was saying, I'm using triplet therapy as a sequential treatment. Should I change? I think the answer is yes. The trials we have use combination triplet therapy, so we should follow evidence. At least this is personal recommendation. I think we're right on time, and we should now move to the questions from APCCC. Let's have all our queen and king of APCCC, CLK and Aurelius.
I'm not a royalist, thank you. But we have indeed some very interesting results, and we will get to the prickliest bush in the garden, as Gert expressed it. I like that expression later on. Just for those who have not been here yesterday, very briefly, the rules of voting. We always assumed that all the options were available, so that was the requisite for the panel members for voting, that the patients were fit, had no relevant contraindications, and there was no possibility to participate in a trial. The panelists could abstain if they did not feel expert in a question, and you see the levels of consensus that have not changed since 2015. And as always, and Nicolas Motte was always very vocal about that, the questions oversimplify, of course, clinical scenarios, and so we always recommend to read the manuscript, which is more a novel rather than a manuscript, because it exceeds all page restrictions of the journal, but we try to really elaborate on additional factors and considerations when you look at these questions. And we start with the first question, and maybe for the people on the panel, it's quite easy to interchangeably use the terminology of these whatever we want to call it, endocrine therapies. And Mary Ellen included a new one, AXA, which is a Swiss insurance company. I like that. We asked, and I think for people who are maybe treating all kinds of diseases, not only prostate cancer, it may be helpful if we could somehow agree on one term. And the first option was AR pathway inhibitors. This is what we always used in our manuscript, 58%. 20% for RC, and then you see all different variations and even terms that we have not voted on here. So clearly no consensus. I don't know whether we need to discuss this. It was an attempt to... Yes, Gert?
Well, I've used NHA to date, but I'll shift to RP. I think I commend you on putting this up, because we're all using different language, and it might be fine for us, but we need to make it clearer. So I think we go with the majorities. In the future.
Yeah. So I think really, like also, as you said, there's so many people who reading papers who may be not experts in prostate cancer, and then if they read a different expression every time, it's also really confusing. You don't know if the same things are included or not. So maybe we can then even take the majority. So thank you very much. And then for our future manuscripts, always use RP, we had the majority. So thanks for that.
Bertrand, would you switch from ARTA to RP?
Yeah, I will switch also.
Okay.
No, I believe ARTA is different from RP, but that's it.
And actually, hopefully, I hope that soon we will have third generation AR pathway inhibitor that works when those drugs have failed. Right. So then we will eventually call those ones second generation, because they were able to show all survival benefit after ADT have failed.
Perfect. So that was the first. So now we come to something very practical, triplet therapy. And here you see, so we use the term high burden, but the high burden includes high volume and high risk, just that everyone knows, that are chemotherapy fit. So the patient's chemotherapy fit. Do you recommend triplet therapy, docetaxel, RP, plus ADT, and you see in light green, yes, in the majority of patients, in blue, only in selected patients, and in yellow, no. You see here is quite half-half. So that's interesting. If you go to very specific situations, again, chemo-fit patients, do you recommend triplet, systemic therapy? Again, in light green, it's the majority of patients. First, synchronous, so de novo, low-burden disease, only 3% in the majority of patients. You see in blue, 47%, yes, but only in selected patients, and 50% of the panelists said no, no triplet in de novo low-burden disease. If we go to metacronous low burden, we have heard a lot about that. The no goes to 84%. So this is a consensus. So triplet would not be given to these patients. And if you go to the rare disease setting of metacronous, so relapsed high burden, you see 34% would give it in the majority, 50% would give it in selected patients, and 16% would not give it. So if we combine, it is a consensus to give, at least in some patients, the triplet therapy. So I start with you, Karim. So do you want to comment on these results?
Yeah, I think probably the most important finding is the one in the center. Again, this is data-driven. The meta-analysis reported last year by Claire Vell clearly showed that for metacronous low-burden disease, there's no benefit from adding the Taxol, and therefore there's no benefit as using a triplet therapy. So I think most people believe the data and follow this evidence, which I think is a good thing. We're serving patients. Now for the two other groups to the left and to the right, I think we all have our bias. For synchronous low burden, the same meta-analysis suggests that indeed the Taxol works. Of course, we all know that it doesn't work in all patients, and it has to be balanced with the toxicity of the treatment. So I mean, we're split here, you know, and probably with all our subjectivity. I simply think it's important to communicate that subjectivity to all the patients and tell them frankly the pros, the cons, and make a decision together with patients. But do not necessarily exclude one option, one way or another in this scenario, especially again, given that all our tools for assessing burden of disease are very imperfect. I think Dana showed this bone scan and then a PSMA PET showing completely different things. We make mistakes when looking at bone scans, when counting metastasis, and we really don't know whether a big metastasis in the pelvis just counts as one as opposed to 3 spots somewhere else. So all this is really relative. We need to discuss this very frankly to patients.
And maybe, can I ask you, Dana, what you think? So if you give it to a patient with de novo low burden, which would be your selection criteria? There were quite a lot of people who were saying, yes, sometimes I do it in selected patients. So how would you select your patients?
So, I mean, I'll be echoing a lot of people say. I rely heavily on the patients as best I can to sort of get a sense as to what they want. Again, you know, these are newly diagnosed patients with metastatic disease, and a lot of them have, you know, some have a lot of fear about chemotherapy, and I'm comfortable enough, particularly in the low-burden de novo population, to just use an ARPI plus ADT and not use chemo, because as we've mentioned multiple times, we don't really have a direct comparison, and I think there's some, you know, contemporaneous STAMPEDE data to suggest that, you know, maybe abiraterone could be better. I don't want to, but than docetaxel. So, you know, I just think that it depends a lot on the patient, and I'm less likely to use it in a low burden de novo patient than a high burden myself. But maybe if your question is who would do it, I think a patient that, you know, is really eager to do everything, not to leave anything on the table, I don't think it's a wrong option. There are a lot of really good right options.
Perfect.
Then we move on. We have more questions on now synchronous low burden patients on conventional imaging. And the question was what treatment recommendation we do, regardless about the decision of metastasis-directed therapy or the addition of docetaxel. So we have a lot of other questions on this topic. We show this one, but because we have a consensus, 82% voted for ADT plus an AR pathway inhibitor plus radiation of the primary tumor. I think, Rob, that was your topic yesterday. Very few voted for ADT plus RP. No one voted for ADT alone, and a few voted for ADT plus radiation of the primary without the addition of a second endocrine agent. And the subsequent question for this patient is about the radiation dose and schedule in synchronous mHSPC. We have two different schedules. We have the one from Stampede. We have also the one from PEACE-1. And you see this panel is split totally across the middle, but I would like to draw your attention that also 29 experts voted abstain on this question, which I think is a fair point. Option 1 is a dose-escalated radiation therapy schedule, 74 to 80 gray in conventional fractions, or hypofractionated schedules that have an equivalent biological dose, or then the lower dose as was used in Stampede, 55 in 20 fractions, or this very convenient schedule of 6 times 6. I don't know, Thomas or Nick, maybe you want to comment on especially this question of radiation.
Yeah, so personally I think that all the evidence that we have is using lower than curative doses, so because all the trials that we have use lower than this normal standard used now. Then I think that we have the correlation between dose escalation and disease control. As soon as you have the possibility to achieve the dose constraints and to irradiate safely, I think that it seems reasonable to propose some dose-escalated regimens. We have different ways. I think that for metastatic patient, probably something with moderate or extreme hypofractionation is more convenient, but this is my opinion, of course. I don't know, James, what do you think?
So the reason we picked the schedule that we picked for Stampede was that you have to remember we were planning this around 2010. And so we were not confident that we could deliver low toxicity radiation to full radical schedules with sort of hypofractionated type schedules. So we opted for the two schedules you see there rather than 74 and 37, which would have been the UK standard radical schedule at the time. We also felt these are metastatic patients with, at that time, maybe 3-year survival times. So we didn't want to take a couple of months of the actually good quality life, which you have mostly when you start treatment. I entirely agree with Thomas that we now know that we can dose escalate and hypofractionate. So for Stampede 2, our default schedule is 36.25 in 5 in a week and a half. Because we think it's likely that higher dose will give you better local control at the very least. And as I mentioned already, we're kind of testing the possibility that we can cure these patients as well. So to give subcurative doses just didn't seem to make sense. So although the evidence is strongest for option 2, I actually voted for option 1 for the reason that I've just said, and that's what we're going to use in Stampede 2.
Okay, thank you very much. I guess we put that in the manuscript. I think that's a very important point. So now we go again to synchronous low-burden disease on conventional imaging. And the question is about additional metastasis-directed therapy, of course, if it's technically feasible. And then when we ask the panelists, you see here, who would do it, 17% would do it without further examinations, 57% would do it, but only if there were no further lesions on a next generation imaging, and 26% said no, I don't do MDT. And I think that's really quite interesting because we have seen in a lot of talks we don't have real good data, but still the enthusiasm for metastasis-directed therapy is very big. And if I remember well, I think Noel Clark has arrived. So he said at one of our first meetings, he doesn't know where all this enthusiasm about the metastasis-directed therapy comes from, because we didn't have data then. We have a bit more data now, but not that much data more. So maybe Bertrand.
I was having breakfast with Declan. I don't know if he's there. because everybody quote PokeMed paper, and we had a lot of backfires from the radiation oncology community. But just as you haven't made huge progress since then. So tonight we're going to write PokeMeds 2, okay?
Can I star in the movie?
Yeah. No, I mean, there is a consensus that, maybe extremes on this, but we do think unless proven wrong. And in the ideal world, I do remind you that the concept of equipoise would actually ask us to do the opposite, but that's it.
So just to push against that, so one of my research fellows, Hoda Ati, who's in the audience, we've looked at what happens at best response on the PET scan. And so for metastasis-directed therapy to be the right thing in the majority of cases, you'd want to see that patients either don't get a complete response, or when they progress at the same sites of disease, oligometastatic disease they had at the start. And the answer is that's actually quite an uncommon scenario. So patients will often get a complete response and then relapse at new sites of disease, and that's a much more frequent scenario than relapsing at the same sites of disease. So I absolutely have equipoise that we should be doing this trial. We should not assume that we can give metastasis. I admit I'm tempted to do it because it's not very toxic. But we really don't know that you might not do just as well irradiating oligoprogressive disease, which is actually something we haven't discussed at all. I think one of the things that's very striking as we do more and more degeneration imaging is you see marked heterogeneity of response to everything, and we might be better off focusing on the stuff that doesn't respond rather than the stuff that does respond, which is mostly what happens at presentation.
Yeah, that's an interesting thought too. Chris?
Yeah, the one comment I would say about radiating, especially the vertebral bodies in my experience, is yes, it's easy to do and it's relatively low toxic, but we should not forget about the bone health. I've seen a number of crush fractures start to happen, so I get particularly concerned and more worried about bone health in patients who have radiated vertebral bodies for crush fractures, which can be very detrimental.
And we show we can do the trial. I mean, Pierre Blanchard is recruiting close to 500 patients in 2-3 years? Yeah. So we can do the trial. So we should put all energy doing the trial and waiting for the result.
Agreed.
Excellent. So the next question was, if in a patient with low burden mHSPC you have used metastasis-directed therapy, the question is, has this consequences on your recommendation on the duration of systemic therapy? Because you probably irradiated the primary, you've irradiated everything that has shown up on either scans, we didn't define that. And you see the options here. If it was conventional low burden and you did metastasis-directed therapy, 31% of the panel voted for lifelong, as was done in the trials. 56% voted, Chris, 2 to 3 years, continuous ADT plus minus an AR pathway inhibitor. And 13% voted for intermittent and interrupt treatment after, for example, 6 to 12 months in case of a good PSA decline. If this patient had next generation imaging and metastasis-directed therapy, the proportions shift a little bit. 17% now only would go for lifelong continuous treatment. 65% now would interrupt after 2 to 3 years, and 18% do intermittent therapy even at an earlier time point. Any comments? It's not yet. It's a kind of introducing the de-escalation concept.
No, but we should ask Nick to comment because I was in the IDMC of Stampede, but the next generation imaging, they fall in between the M0 and the M1. And correct me if I'm wrong, Chris, but the hazard ratio was quite similar for those receiving 2 years and lifelong, no? Nick?
Yeah, so in essence, option 2, which is the most popular option, is written into the Stampede 2 protocol as a therapy option, and this seems to have broad support, and I think it's the right thing. I mean, we know these patients have very long survivals, and we have to be really mindful that you're potentially harming a lot of people by giving them long-term therapy. And I think with very good tools for monitoring, you can reintroduce treatment very quickly if patients are going wrong when you stop the treatment and testosterone recovery occurs.
Michael, can we ask, you did a beautiful talk yesterday on monitoring. Would you be comfortable in stopping treatment after 2 to 3 years?
Yes, because, I mean, by that time, Nick is completely right that, you want to give the patient the therapy for which we have evidence of a survival advantage, but you are pushing castration resistance at that point as well. Plus, you have a fair amount of testicular atrophy after 2 to 3 years. So the issue of really like intermittent therapy, when it's going to take you a long time to actually mount testosterone to sort of reconstitute. So I think that there is, at least from a research perspective, a role for getting a PSMA scan, seeing what the residual disease is, irradiating that in order to cut short the 2 to 3 years. That's the whole research question there. So I would have answered it a little bit differently in terms of the previous question. Is there a role for getting a PSMA scan so that you can irradiate the residual disease specifically to stop the systemic therapy? But again, that it's an open question. I think it's a research question, not necessarily a standard of care question.
Well, maybe I'll be the devil's advocate here. Just to remind that we're speaking about de novo disease, which is not good, really, even if it's low burden. And we also have data from the SWOG randomized phase 3 trial with a 10-year median follow-up showing that intermittent hormonal therapy is non-inferior to continuous treatment. And if you look at the medians in overall survival, that translates into about a year of difference in overall survival. So that's not nothing, potentially. So I think we should be cautious. It's really striking that 10 years ago, everybody was using continuous ADT as their main treatment. Of course, stopping in patients with severe side effects, comorbidities, these things. But in fit patients tolerating okay the treatment, we were continuing. And out of a sudden, we tend to recommend, or at least in our practice, we stop in obviously the majority of men without data, and actually with some data telling us that we should not. So I think we should really be cautious about that. Now, having said that, the caveats from the SWOG trials compared to the current situation is that, number one, the cutoff, the PSA cutoff for stopping was 4 and not 0.2. So we're probably better selecting patients now who are very good responders. So that's a very important caveat. And number two, the question was in a context of MDT, so radiation therapy directed to the metastasis, so potentially a greater effect. But again, I think we should still be cautious. I think we should do that in a context of a randomized trial. Bertrand has one, the pharma industry has another one. I think that's very important. Otherwise, we may really do mistakes in our practice.
Okay, so please all help us to really recruit patients to these trials. I think we all want to know the answers. So now we talked a lot about treatment de-escalation. I think is really a hot topic. And we had some questions about that. So for the majority of patients with a deep remission to systemic therapy, and we did define that as PSA below 0.2, and no relevant side effects, what do you do about treatment interruption? It's a bit what we discussed about now as well. So you see here, who would, now the question is, recommend treatment interruption? And you see 7% would say yes after 6 to 12 months. 40% would say yes after 24 to 36 months. So probably Chris, 24 months is in there. Then some people, 6% would say yes, but only if it's more than 3 years. And then 47%, almost half, would say no, I recommend continuous therapy. If we now ask the question, who would at least discuss it with their patients, the picture changes a bit. You see here, only 26% would not even discuss it with their patients. So I think I ask Matthew maybe, what do you think about these votings? What do you think personally about interruption?
Yes, I view it as a shared decision-making, and would be in the group that would discuss it with the patient, share the information with them. I also add that the context here of no relevant side effects is a bit in the eye of the beholder, right? That also requires a conversation. If you ask the patient, how are you feeling? And they say, fine. I don't interpret that to mean they have no relevant side effects. You really have to ask the right questions. And some of the patients who suffer the most from side effects of ADT may respond in a manner to satisfy their physician, right? They'll say, I'm fine. They say they're fine because their PSA is undetectable. So you really have to ask the right questions to understand how well or poorly they're tolerating the treatment.
Mary Ellen, what are you doing? Are you...
Well, Chris and I practiced together for 14 years.
Oh, so it's the 24 months.
Yeah, we usually stop or have a conversation of stopping around 24 months. Some patients don't want to stop, so you know, it's a conversation, but we're at peace with that, especially if they're low volume, low PSA, and have had PSMA PET and had their mets radiated.
So the next question, if we follow up on that one, what are you stopping? You've seen from Bertrand, there is different approaches in the different trials. So here, suspend the RP only was 19% of the panelists. Suspend the ADT only was 4%. And 77%, so consensus, would suspend both the ADT and the RP. So as we do in P6. Some comments on this one? Maybe Oliver, can I ask you what you think about it?
You know, it turns out that when you suspend both, it takes a long time to recover. We talked about the testicular atrophy that was there. Nevertheless, in our practice, we do suspend both. You know, it's a little bit interesting. I want to go back to the PSMA PET just a tad. You know, there is a lot of reliance on the PSA alone, and I think there's a fair amount of heterogeneity that we don't fully understand. And even though it's certainly not established as a type of care that we can endorse in a large panel, the utilization of the PSMA PET here is potentially helpful. Getting back to Nick's point a little bit earlier, you know, do you want to eradicate the lesions that you see initially, or do you want to eradicate the lesions that are persistent after a period of therapy? And I think that's a very well phrased point, because the truth is, I think we want to eliminate the ones that are persistent. And do we need to wait 2 years for that? So a little bit of complexity here, just thinking about that interplay between molecular imaging, the PSA itself, duration of therapy, and then what we do in each one of those circumstances.
Thanks, Oliver. Bertrand.
I think an important consideration is, why do you stop it? So I agree with, I repeat, it's experimental. If somebody is experiencing cognitive difficulties, instabilities, I would stop the RP, where if somebody complains of sarcopenia, muscular weakness, fatigue, I would stop the ADT. So in a world where we have not demonstrated that it's good as regard to standard outcome, we do it, and I agree with Karim, in most patients who complain. So once again, it's about what they complain, because both have different toxicity. And that's very of note. We're going to submit that at ESMO. When you stop the ADT for muscular weakness, very rapidly testosterone kicks in, and if you make them exercise, they regain very rapidly their muscular strength on the RP alone.
Yes, I was just going to address this to Maria, because you talked about the frail patients. Is this something that should be more considered in frail patients that responded well with a PSA less than 0.2?
Well, I totally agree. I think this would be an important move, but I think key is to make the patient move, and a patient that is lying or sitting in front of the TV and just having ADT and ARPI will have difficulty in regaining muscle strength. So I think it is the whole concept that we have to follow in this case, and when stopping, then they have a good chance also to regain muscle strength.
Excellent. So we have danced a little bit around the prickliest bush. We haven't solved the question, but the trials are ongoing. And just because, Gert, you showed this question in your talk, we thought we should address it before we all go for coffee. And this is now in patients with synchronous mHSPC, and you have done tumor genomic profiling or germline testing, and they have a pathogenic BRCA alteration. we asked the experts, does this information change your treatment recommendation for this patient? Option 1, yes, more triplet versus doublet therapy.
That's interesting, yeah.
ADT, RP plus docetaxel versus ADT plus an AR pathway inhibitor. Option 2, nobody voted on adding a platinum, I have to say. Option 3, yes, you would add a PARP inhibitor, even though we have not seen the trial data that are ongoing. And option 4 was no. This information does not change your current treatment recommendation. We didn't specify high volume, low volume, etc. Who wants to comment on adding a PARP inhibitor already now?
Maybe Gert? Oh, sorry.
Michael?
No, this is doubly irrational. We don't have data, actually, that docetaxel is superior to ADT and an ARPI, right? We don't know that ARPI plus or minus DOSI, that the DOSI is additive in terms of benefit. So now we're going to say, why don't we throw a PARP inhibitor into that as well? There just isn't data for it, for HSPC for that combination, and so it goes further into a data-free zone, bringing therapy into a context out of the context of a clinical trial without justification. It's my opinion.
Strong point, yes.
Maybe also Gert, who is leading the Stampede arm with the PARP inhibitor.
Yeah, and I've already made my point clear that we should not be preempting the results of a trial, especially with a drug that could be toxic. And I made the point that we need to be cautious about RPFS. If we see an RPFS benefit, case closed, I think.
Chris, last comment.
Very quickly, I would just say, Michael, we are desperately trying to get the data from Chartered and Enzymet, where we got germline DNA and the somatic tumour. So we should be able to do exome sequencing and have that data for with or without docetaxel, with or without the ARPs in Enzymet, hopefully within the next 12 months. So stay tuned, and it's all part of the collaboration with the Stampede team per Gert's slide. There's challenges with exome sequencing without germline. We have it for Enzymet and Stampede, but and Chartered, so it's work in progress, but it's not easy, but it's going to come. It's going to come, is the message.
And we're going to talk more about PARP inhibition, of course, in session 5 after the lunch break. But after the coffee break, we will focus on side effects.
Yes, so please all come back and have a nice coffee break. Very nice.
But I'm pleased that the consensus was for radiotherapy for low volume synchronous.